Greetings from the University of South Florida in Tampa. My name is Dr. Claudia Cooperman, and I'm an associate professor and the assistant dean of undergraduate studies in the USF College of Public Health. Thank you for joining us for the launch of the fall term Global Health Conversation Series. We've all been extremely busy responding to the current pandemic and ensuring the public health continues to make positive strides towards eliminating this pandemic. Although we're all working hard towards this end, we must not forget the other public health issues that continue to exist. This is why the theme for this fall's Global Health Conversation Series is Advancing Global Health. Please note this session is being recorded and will be made available to everyone after this webinar. Before I introduce Dr. Simmons and Dr. Zgibor, I want all of you to know that this webinar will be interactive. Dr. Simmons will ask questions during his presentation. Please feel free to raise your virtual hand to be given permission to use your microphone. Once you're finished or your question's been answered, please remember to mute yourself again. Alternatively, please feel free to type responses in the Q&A chat box. Dr. Simmons and Dr. Zgibor will have time at the end of the presentation to answer any questions that you may have. Now let me introduce Distinguished Professor David Simmons. Professor Simmons is a professor of medicine at Western Sydney University, Macarthur Clinical School, head of Campbelltown Hospital Endocrinology Department, and the director of the Diabetes, Obesity, and Metabolism Translation Unit. He has worked nationally and internationally. He was the foundation chair in rural health at the University of Melbourne, inaugural professor of medicine at the University of Auckland, Waikato Clinical School in New Zealand, and lead diabetes consultant at Cambridge University Hospital's NHS Foundation Trust, joining Western Sydney University in Australia in January of 2015. With over 380 referred publications, he's won several national and international awards for his work in diabetes epidemiology, diabetes in pregnancy, and diabetes service development. He is a past president of the Australasian Diabetes and Pregnancy Society and was a member of the World Health Organization Technical Working Group on the criteria for hyperglycemia in pregnancy. He was previously the chair of the Diabetes UK Health Professional Education Steering Group. Professor Simmons works with the University of Örebro, Sweden, and is a professorial fellow at the University of Melbourne. Professor Simmons is the recipient of the American Diabetes Association 2020 Norbert Freinkel Award for his outstanding contribution to the understanding and treatment of diabetes in pregnancy, and the 2021 recipient of the MDRF Gold Medal Oration. We're very pleased to have you here today. Dr. Zgibor wears many hats, and she's near and dear to our hearts here in USF. She's a pharmacist, an epidemiologist, the associate professor in epidemiology and biostatistics, the director of our DrPH program, and an associate dean for academic affairs at the University of South Florida College of Public Health. In addition to these roles, Dr. Zgibor remains actively involved with projects at the University of Pittsburgh, her alma mater. She is a co-investigator on a study called Move Up, which is a translation of the Look Ahead study. This intervention is a community-based trial examining the impact of this intervention on weight loss and physical function in older adults. Dr. Zgibor recently completed a cluster randomized trial in primary care entitled Redesigning Medication Intensification Effectiveness for Diabetes, Remedies 4D. This study used treatment protocols for treatment of people with type 2 diabetes. In diabetes education and educators in 8 non-academic primary care practices successfully implemented these protocols. Significant reductions in HbA1c and LDL-C were successfully implemented and observed. These protocols were subsequently implemented throughout the health system. Dr. Zgibor has experience in data collection and analysis of medications and longitudinal studies. She serves as a scientific reviewer for the NIH Dissemination and Implementation Study section. the special emphasis panel for the NIDDK review of natural experiments, pragmatic trials, and the Health Services Organization and Delivery Study section. In addition, she has worked in diabetes research for over 20 years and has more than 100 publications. It is our great pleasure to have these two scholars here today, and we're very grateful to hear and learn from them. Dr. Simmons?
Thank you. Thank you, Dr. Cooperman, for that very kind introduction. It's a great pleasure to be here in kind of cyberspace from the other side of the world and to talk about something which is really very obviously important from a global health perspective. And I've got no relevant disclosures. So at the moment, you can see me, of course, in the rightful place at the top of the world in Australia. And if you look down in the bottom left-hand corner, you can see where in Australia I am, just south of Sydney, in a place called Campbelltown. And we're currently in lockdown due to COVID. It's a multicultural area, and diabetes is a major challenge. There are many people from around the world, including those from the Pacific Islands. And today I'm going to talk about people, and Māori and Pacific people in particular, from New Zealand, which is just over, looks a little distance, but actually it's quite a good way away. So the indigenous people of New Zealand, the Māori people, they came over in about 800 AD through these giant waka or canoes, and there were 7 landings, and the descendants of those are our Māori today. Polynesians moved to Hawaii, so part of the US, to Easter Island, and were really expert in going across the Pacific and surviving those very long, cold and wet journeys across the Pacific. More recently, Pacifica from other islands, from Samoa and Tonga and others, they were encouraged to come over to New Zealand to work in the 1960s, but in fact the first group of Samoan migrants was in 1874. So Māori and Pacific people and those of European descent have been living in New Zealand for obviously some time. Those of European descent came over in 17th, 18th century, and in 1840 there was a treaty signed between Māori and the Queen at the time, and which was to make the country a bicultural country. And there were still, as you would expect, still conflicts and the Māori Wars. But in 1867, Māori electorates were introduced, so that Māori have had representation, and those have grown in number. And by 2021, 29 of the 120 New Zealand MPs are Māori, and that's with a population of 850,500, which is 16.7% of the population. And Māori have been represented at all levels in government and in organizations, and in academia, and so forth. And that's very relevant, I think, to the issues of governance over health in particular. And Māori have a different view to the Western view. We would be thinking about physical and mental health in our kind of Cartesian view. But for Māori, there is also the family, the whānau, and also spiritual health. So where they would say perhaps, and in the past, one of the kamata, one of the elders would come along and say, yes, I've got diabetes and I'm on dialysis, but my mind is bright, my family is supportive, you know, I'm in touch with my God. Actually, I'm 3/4 healthy. So a very different view of health to those perhaps from the West. However, when we do look from a more public health view, you can see here in terms of life expectancy, yes, it's been improving. Those of Asian descent in New Zealand have got the highest life expectancy than European women, and Māori women, and at the bottom, unfortunately, are Māori men and Pacific men. You can see in those graphs. So in spite of all of the governance issues across the country and so many other things, Māori and Pacific people still have major health demands. And it's important to know, especially for you in the US, that New Zealand has a capitated, taxpayer subsidized, universal health system. The government, the taxpayer, pays for 80% of total health expenditure, and it only represents 9.5% of GDP because of the efficiency that brings. Hospital and specialist services are free at the point of care. Medications are subsidized, so there is a co-payment of $3.40 for the first 20 prescriptions per family. GP visits, primary care visits, are $10 to $34 per visit, which is actually quite a lot if you're quite poor. But if you compare it to you guys in the States, that's pretty cheap, I would think. So the out-of-pocket share is about 18%. In the OECD, it's about 27%. And diabetes disproportionately affects non-Europeans all over the world, but that includes Māori and Pacific people. And the impact in New Zealand of diabetes, and I think this will be an underestimate, is 0.67% of GDP, is diabetes alone. That's a massive proportion. And again, that's important in terms of policy. You'd expect a big focus on this. And for those of you who, I'm sure you all know that diabetes is a higher glucose in the blood, and there are other disturbances of other metabolites. Type 1 diabetes is predominantly autoimmune, where the body attacks itself. Type 2 diabetes is what we're going to be talking about. And there are a range of causes behind that, but it's where there's insufficient insulin to meet the demand, and the body has some resistance to insulin in most cases. There's gestational diabetes, I'll comment on that, which is hyperglycemia, first diagnosed in pregnancy, less than overt diabetes, and there are some rarer forms. And I know we're all in the COVID pandemic, but actually the diabetes epidemic is the largest epidemic, the largest pandemic the world has ever seen. And these are numbers from the IDF, and 3.7 million have been dying per annum, and that's been growing due to diabetes. And you can see that 2019 was 463. If you look at COVID-19, and obviously it's been devastating some of our families and our neighborhoods and our people, and it's a terrible thing, and our economies. 212 million was by the 7th of August. That is still dwarfed by the number of people with diabetes over time. And that's 4.44 million deaths. Well, this is 3.7 million deaths per annum. And on the ward that I'm in, that I've had just a few hundred meters away from me, 50 to 75% of those with COVID on our COVID wards have diabetes. So diabetes is contributing to the deaths and harm that COVID is doing. We should have already had this pandemic under control. And in New Zealand, when I was working there many years ago now, as you've heard, we made predictions. We thought in the Pacific community that numbers would increase by about 100%, would double by 2021, 90% among Māori, and about 39% in those of European descent. We thought by 2021, in those, we thought they were very conservative, we thought they were pretty bad predictions. We thought there'd be 150,000, there's 253,000 in this small country of 53 million. And the place which is the real hotspot, you can see down on the bottom, with the most, is South Auckland, where I used to work, and I'm now still working with. And you can see here on the map, on the right, there's a nice map of New Zealand. Auckland is the big smoke, is the city, and there in green, just south of that big red dot, is South Auckland. South of that is the Waikato, this district that again I used to work in. And at that time in the 1980s, people were walking in with end-stage renal failure. There were many stillbirths. The neonatal intensive care unit had many babies of women who had diabetes, increasing numbers on the ward, high rates of amputations. And this is 30, 40 years ago. And one of my mentors, Dr. David Scott, set up the first diabetes clinic there, a walk-in center that was free, and a gestational diabetes clinic, and started training up lay educators for people who were not at that time able to come to universities. Much changed now. Many Māori and Pacific nurses totally embedded in, but then was uncommon. And I set up the South Auckland Diabetes Project to try to enumerate what was going on and try to guide a range of interventions. You can see a household survey of 100,000. 5-year follow-up study, undiagnosed disease study, looking at complications like eye disease, lots of audits in the hospital. And we had as many interventions as we could, and I'll come to those. And particularly something called the Diabetes Care Support Service that has run for 25 years, auditing what's going on, trying to give advice to GPs about how to improve their care. And you'll see the data from that. So when we look at diabetes in Polynesians, in Pacific and Māori people, number one is, and this is old data, so the numbers are up now, you can see that this is using a cutoff of 31, which is a Polynesian cutoff. Europeans' prevalence of obesity at that time was about 25–30%. But even at that time, Māori and Pacific people were 2/3 to 3/4. And we're just involved in a study in Pacific people in Sydney, and 95% of the Pacific people are obese or overweight. And Māori and Pacific people, this is the prevalence of known diabetes with a door-to-door survey. And you can see that most are Niuean, which is a Pacific group, Māori, South Asian are up there, Cook Islands, Tonga, those from the Middle East, Samoan, European and Chinese, interesting at that time at the top, they very much moved up the league. In green, you can see that's the known diabetes that you just saw. And at that time, there was one undiagnosed for every diagnosed, but in blue are those with pre-diabetes. And that's the equivalent of known plus new together. So that's a lot. If you add the metabolic syndrome, which is those in red, you can see that actually it's about, even at that time 20 years ago, was about 60% had some form of metabolic disorder. And the age at diagnosis among Māori in the orange in the middle and Pacific people in red was somewhere between 5 and 10 years earlier, giving them more time to develop their complications at a time when they're more susceptible, as we now know. And because of that young age of diagnosis, many more of the women had diabetes in pregnancy. So even then it was 6% in Europeans, it's more than that now. But Māori and Pacific people, even then, were 1 in 6, 1 in 5, many more than that now. And the complications that we're talking about, this is a meta-analysis now from 2021. This is just out in DrPH, which is across 2.4 million from multi-ethnic studies, 23 prospective studies. At the top, you can see different groups of African descent, Hispanic Americans, Māori and Pacific people. And you can see that when you make adjustments, in fact, the all-cause mortality for those with diabetes is roughly similar when you compare with Europeans, except among Māori. Māori still are 88% higher death rates. So this group really does have a much higher rate of mortality with their diabetes versus other ethnic groups around the world even, including Pacific people, which is interesting because they're both Polynesian groups. But if you look at one of those studies, which is taken from our one, we can get a bit more granularity of what's going on. So this is the standardized mortality rates in 1999. Europeans are between 219 and 348 per thousand. Māori, 461 to 903. You can see that's a 650 rate. Pacific people are in between. But what are people dying of? And this is something which is just so pivotal in this. Look at this kind of strange purpley mauvey color. And you can see here for Māori, these incredibly high rates of death from end-stage renal failure, incredibly high rates. Also high rates in ischemic heart disease, perhaps comparable in malignancy and other causes. And I'm showing you this one because it's just so stark at that time. These higher rates, this is the number of people on dialysis, renal replacement therapy. Very few were having transplants at that time for a range of reasons. So many more, and yet they're just 1/6 of the population. So this is huge rates of end-stage renal failure. And that's very material for some of the interventions that we would have expected and wanted. But with kidney disease, a parallel, could have gone through other complications. You can see visual impairment at the time, 3 to 4 times higher on the top left for Māori and Pacific people. Laser therapy at the time, 1 in 5, so 2 to 3 times the rates. Cataracts showing the time that the high glucose had been there, very long exposures leading to those higher rates of cataracts. So here you go, question number 1. And, what are the possible reasons are there for these ethnic differences in diabetes prevalence, complications, and mortality? And, we'll give you a couple of minutes to put those up in the chat. And Janice is here to moderate those. And we're very interested in what you have to say of what you think are the causes for this.
We see diet and health-seeking behaviors. Let's see, access to food, the European diet, fish and chips, previous fear of the white health system. Let's see, diet and environment, environment, cultural lifestyles, cultural factors, poverty, genetics, limited access to fresh produce, or even limited access to reliable transportation to access fresh produce, access to resources, diet, and genetics. Let's see, combination of traditional foods with decreased activity given the current society, culture and fast food, income.
I think that's
it.
You think that's it, Janice?
Yep.
Okay, so that's very helpful. So I'm going to take you through, because we are going to adjust for some of those things in these next set of analyses. So when I arrived, one of my mentors, Betty Hunapo, who was the head of the Māori Health Unit, said, don't just tell us what the problem is, help us do something about it, which, you know, really is the key message. Epidemiology on its own has to have some translational aspect. You've got to intervene, you can't just describe. So we first of all looked at barriers to care, and we put them into 5 groups. And Janice knows this is one of her papers as well. And we looked at people's interaction with others, the psychosocial, education, knowledge, external physical with regards, you know, cost and physical transport, internal physical, other conditions, and psychological, some of those willingness to change behavior, changing foods and lifestyle and so forth. And indeed, there were ethnic differences in the responses, but of course, part of that may be the way that we ask the questions, so we don't necessarily just look at the numbers, but certainly the ranking. Low diabetes knowledge, people said that they didn't know enough at the time. But low system knowledge, health literacy, and how to use this system, which was free, but how do you get access? How do you actually do what you need to do to know how to change? Decisional balance is, you know how to change, but you're not necessarily changing for a whole range of reasons. The disempowered group comes up with some of these cultural issues, the physical access, personal finance, the poverty, which I'll show you some of the rankings of that, lack of support, particularly among Māori, and some of these, perhaps some of this colonization and the wider things around that, and social pressures, service organization. So that's the top 10 or so. Now, to deal with this, we then brought together a multidisciplinary, multicultural planning group with a committee from all over, including local government. And number 1 was prevention. Let's alter the environment, address those food supply issues, training people, all those kinds of things. Start a quality assurance program with feedback and make sure we can address some of those issues. And we set up the Diabetes Care Support Service. I mentioned this audit in general practice. Get better information, so auditing wherever we could. Get a coordinator. You can't just let these things be random. You need a coordinator on a population basis for this district, which is was being just so hit by diabetes. And this is 20 years ago. Develop support groups, people helping each other, community activation, remove those cost barriers, improve the hospital care of different sorts, improve access to all of the different diabetes-related specialist services, improve the screening. And in fact, I won't show this, but screening is very good in New Zealand now. They reckon it's only about 10 to 20% undiagnosed across different ethnic groups. Improve the follow-up of those with pre-diabetes and improve the follow-up of those with gestational diabetes. Pretty good plans. So we, as the South Auckland Diabetes Project, we set up a whole training program, the lay diabetes educators that became community diabetes educators, and they went on to jobs in nursing and other things, but also used their cultural skills to deal with things. Programs in the churches and the marae, which are the Māori meeting houses, diabetes peer support groups. We set up ways of addressing other barriers to care, the costs, the medication packaging for health literacy, a whole range of things. We developed tools with the community, the Māori and Pacific communities, quick ways of assessing knowledge. So if we had an intervention, we could assess their behavior and so forth, looking at readiness to change, validated among Pacific people, different tailored interventions with videos and leaflets. And we piloted these in workforces which had high Māori and Pacific members. We developed a whole strategy for working with Māori and Pacific churches and Māori community organizations, with strategies, meeting the key decision making, looking at the different networks, where's the power, who do you need to work with, identify other resources that could come in, preparing a formal explicit agreement to maximize community empowerment with regards to budget and memorandum of understanding, making everything clear, establishing partnership committees, get terms of reference, all of those things, get a community coordinator, and then the training, maximizing community involvement to first sustainability, which is really what we were looking for. Here's an example. You can see how old this is. Look at that TV, how they used to be. But this is on a marae. This is where people are coming for training, and at the back you can see a couple of my team members. And so this particular one, which we had as a controlled study, looking at two different Samoan churches, church-based. They had a pre-existing board. It was Seventh-day Adventist. We were introduced by our Pacific cultural liaison person from the hospital. There was we had a coordinator who then became the church health leader. That was pretty cool. The new minister there, the wife was a nutritionist, and they raised the money for repeat assessment and to continue. And we had a control group. So we evaluated. The participation rates were pretty good. 78 people in this church, and almost half of them by the end were attending by the end of our evaluation, were attending our exercise program. The readiness to change, on the left you can see maintenance is where you want to be in the blue, and in the white is those people who, whatever you say, they're not going to change, they can't, they're just stuck in their ways. The ones in the middle are persuadable, and you can see that by the end, really virtually everybody that was persuadable was in maintenance. So people had changed across this whole community, and this is versus the control. 144 in that control church. They turned up for their assessments, 85%. The second assessments, almost everybody turned up. The screenings we did, but the follow-up to the glucose tolerance test, 2/3 did that in the intensive group because they understood what was going on, but the control group, they didn't turn up because they didn't know about some of these things. Really important principle for evaluation. At 2 years, the weight had not gone up in the intervention church, had gone up 3 kilos in the control. The waist was down, the knowledge was up massively, activity was up massively, and fat intake was down significantly. So I left, in fact, in 1998, and I still work with the area a bit, but things went on. And I want to just describe what happened since. There have been interventions from the 2000s, the Diabetes Care Support Service, a complications update, and what's been happening. So we had that plan launched in 1992. The Health Authority, the funders, they evaluated, they said this should be funded. And in 1994, this plan was published, was the first ever peer-reviewed published district plan globally. We reviewed in 2000, and those within the diabetes services and what took over from me in the Diabetes Projects Trust, there were changes and things were done there with research money and so forth. There was no coordinator appointed. There was no increase in staffing. There was no process to respond or even to monitor clinical incidents. Although we had our Diabetes Care Support Service, there was no real articulation with funding or with the ways of changing. Now we're 2021, and we've been able to evaluate that. The Diabetes Care Support Service came to an end. And we're now using the data to say, well, what happened and what's happened in between? Well, there were many interventions. So the Diabetes Projects Trust did have a range of peer support programs, but they were on research funding. Nothing ever went further, and I'll comment on that a bit later. There was a community diabetes team, came a chronic care management team across general practices working together. There were $10 million in a prevention program in about 2008. There were localities moved to a general approach, really, from that Let's Beat Diabetes and the community diabetes team. So there was a general physician going in, giving general advice to the GPs, nothing specific, no specialist diabetes advice. There were some things funded for assessments by government across the country, ways by which primary care were better organised, and Māori health providers came in to address some of those cultural issues, and there were Pacific health providers as well. And our Diabetes Care Support Service carried on giving feedback to the GPs where they were, and it's been the same data set for 25 years. And during that time, you can see there's been a 7-fold increase in the number of patients with diabetes per GP. That is a massive increase. And we published in Lancet Global Health at the beginning of this year the 25 evaluation of the mortality in hospital admissions. We have other things coming. This is 47,000 people with type 2 diabetes, 25 years. And what you can see on the left is you can see that European on the left, Māori in the middle, Pacific on the right. You can see per 1,000 person years, the hospitalization rates for cardiovascular disease. And they've all increased massively over this time for those people with diabetes. Look at that, that is incredible. And for end-stage kidney disease, per 1,000 person years, again, increased massively from virtually nothing, when people really were dying. With the introduction and greater access to dialysis, these numbers have gone up massively, which you can see, particularly among Māori. But the thing that's really important here is the age. So the mean age among Europeans is 62, but for Māori and Pacific people, it's 10 years younger. So this is the same graph, 10 years different. So now we have to look at things by age. And this is the first one. This is all-cause mortality among those with diabetes, among Māori. And what you can see is that Māori are dying at twice the rate. The hazard ratio is 1.96. And you can see the biggest difference is in those aged between 40 and 70. Pacific people are just a little bit above those of European descent. And the thing is, this is adjusting not only for gender, but the index of multiple deprivation. So this is addressing the socioeconomic factors. This is addressing those smoking differences that I'll show you. This is addressing the body mass index, but also the duration, which 5-year time period. So this is addressing many of those things that came up as possible causes in the discussion in those answers. And here you've got the rates for cardiovascular hospitalization, and you can see that it is increased in Māori and Pacific, but it's particularly among those very productive ages between 40 and 70, where it's very much almost double, really. And look at this for the kidney failure side. Yes, it's double among Māori, 1.5 times among Pacific, again, adjusting for all those other factors. And what you can see is this massive difference at the age of 50. I mean, that is several-fold difference at that age. The younger ones may be some mixture with type 1 diabetes and some of the coding, we think, much smaller. So here's a quick summary of where we are. South Auckland is a diabetes hotspot with substantial excess morbidity, mortality, and sorrow due to diabetes. The loss of kaumata, the loss of elders, the loss of wisdom in these communities is really having a bigger impact. The impact of the epidemic has been increasing massively. Māori and Pacific people have higher mortality and hospitalization. So why do you think these ethnic differences have continued, seeing that we've adjusted for some of those other things? Why do you think? And Māori and Pacific, you're seeing this divergence between them, even though they're both Polynesian descent. So over to you, Janice, for maybe some answers.
Yeah, so feel free to type your answers in the chat to what you
You've
think.
got genetics and genetics.
Genetics, how have things changed in the past 10 years? These are the parents or grandparents of the present generation. How are things now? During the time when you were working with the program, were there major funds needed? What might explain the differences in renal function between the groups? Nothing really addressed to young people to change their lifestyles. The loss of culture from the older and middle generation.
Good.
Yeah.
Okay, let's continue the story. Sad story, but we did get some wins because of this data. Getting them. So what's been happening in diabetes management? And those lifestyle programs that I mentioned, they were whole communities, so they were young people as well. But I'll come back to that as well, because that's a very good point. So this is this cohort. And I know it's a busy slide, but I'm going to take it through, because on the left you see everybody, and this is for the ones to do with metabolic management. European 15,000, Māori 6,500, Pacific 10,000. And there are more women with diabetes in the Māori and Pacific cohort than European descent. The NZ-DEP scale, so 16% of Europeans were in that bottom least deprived. It's about 68% in Pacific. So actually Pacific are more deprived than Maori, but Maori are at the highest rate of these terrible complications. But smoking is higher among Maori, but again, we've adjusted for that where we can. Diabetes duration is the same. Antihypertensives, look, actually Maori receive more treatment. Statins, Maori receive more lipid-lowering agents. Insulin, Maori receiving more insulin. With oral antihypoglycemics, again, Maori receiving more. Oral anti-diabetes agents, again, Maori receive more and Pacific are receiving more. So it's not about whether people are being given medications. If we look on the left, and this is a really critical slide, if you look on the left, you can see that the blood pressure is relatively unchanged and is comparable between the different ethnic groups. So this system is able to manage blood pressure with no ethnic difference. If you look on the right, what you can see is, in this one, I'm talking about the colors, but the blue are Pacific people at the top, red are Maori, Asians are in orange and yellow there, mustard, and black at the bottom are Europeans. And what you can see is it was very terrible at the beginning. Things have improved, but for the last 15 years, there's been a 1% HbA1c difference between Maori and Pacific people and Europeans. Now, if this was about a system that was, for example, discriminating in general, you wouldn't expect blood pressure and H1C to be discordant. Doesn't mean that the system isn't blind to the greater need though. Now here, we look at the first 5 years of coming into the Diabetes Care Support Service and what's been happening with the mean blood pressure, systolic, the body mass index, the HbA1c, and the blood fats at the bottoms. And this is adjusting for gender, index of multiple deprivation, smoking, obesity, diabetes duration, medication, and the period again. And what you can see is that the systolic blood pressure remains higher for the whole time among Europeans. Body mass index, actually, when you adjust for everything, in fact, it's Maori that are higher, but HbA1c, Pacific people are so much higher. This is in millimole per mole. Maori are in the middle, Europeans at the bottom, and then the blood fats is actually not that much difference. If you look at what that means in terms of achievement of those metabolic goals, you can see that the HbA1c, it comes down a bit, but really you would hope that there'd be a much bigger impact at the beginning after diagnosis than you can see. And half of those of European descent are within target, but it's under a third of those who are Māori and Pacific. Systolic blood pressure, around half of Māori and Pacific, over half of Pacific people, and European descent are 41%. Lipids are actually about the same. And what about attendance? Is this about people aren't attending enough? This is per annum consults. And when we had the coding right, you can see that the consults actually probably higher among Māori. You can see that there's not that much difference. This is 10 visits a year to the GP for those with diabetes. So this is not about getting the access to that primary care. However, what you can see, and this is data about being followed up for those with an HbA1c above 9%, really bad glucose control. And what you can see is that in this South Auckland area, there's half the access to specialist services for even 1 or more times for those with poor glucose control, and it's about a third for 2 or more times. So similar access, greater need, no coordination. Attendance at primary care still has a small cost. If you're attending 10 times, that's actually quite a lot of money. And the most important thing, I think one of the most important things, new, very effective diabetes drugs were not brought into New Zealand 8 years ago when they started coming out. And Māori and Pacific would have had the most benefit. And these actually reduce renal disease, and I'll show you that very soon. And they were not brought in. Lots of cancer drugs were brought in, but not the diabetes drugs. Public health prevention programs, these are complex. And I know there's a US DPP slowly rolling out. But here we've got a program which we were trying to roll out across New Zealand in primary school children. Most of these programs haven't worked much. On the left, in the Waikato, the area to the south, 36% of school children were obese or overweight. And then in 2011 to 14, New Zealand was 32%. This improved in that area, that small little bit. So New Zealand didn't change, the Waikato did. This program was not adopted in South Auckland, and actually its funding has just been seized. We had another program among Māori. It was a 3-year funding, and here's the Māori community health workers involved. In those with pre-diabetes, impaired glucose tolerance, the weight went down by 5 kilos. In those who were normal, went down by 1 kilo. With this program, no continued funding. I left, so I've set up our whole program in Sydney. We now have a randomized trial, custody trial across 48 Pacific churches, which has been delayed by COVID. And it started in this pilot in the Samoan community, Le Toafua. And this was community facilitator, a coach, the coordinator, like in those churches at the beginning, in those Samoan churches. We train up peer support facilitators to then support their community. We have tailored tools of different sorts, pedometers, water bottles, cards, lifestyle programs within the church. We have physical activity programs. You can see what sort of food there was being eaten on the left, the feasts in the churches, and look what it's turned into on the right. These changes are possible when you work with a community. And this is what we achieved. The H1C dropped. This is in millimoles per mole, but it was about 0.4%. In those with diabetes, it dropped 0.7%. That's the same as a drug. Blood pressure was relatively the same, but look at these increases in physical activity. It's only a 4-month intervention, 4 to 8 months, increase in changing their food, changing their physical activity. These can be done, but this is a lot of effort. It's very hard, and it seems as though people don't really want to fund them. And I want to show you what still could happen. And this is a comparison of using one of those new drugs, the SGLT2 inhibitors, versus other things like bringing in a sugar tax and these lifestyle programs that I'm involved in, still involved in, and completely committed to, because they do lots of other things. And this is the decision tree. And you can see in the blue at the top, this is across Australia, it's Australian modelling, and the slides given to me by Jed and Deanna Magliano. And you can see the rate of end-stage kidney disease in Australia over time with no intervention. The red and the purple are lifestyle interventions and the sugar tax. If you wanted to impact on kidney disease, you'd bring in SGLT2 inhibitors, which is in maroon. If you want to turn around the epidemic and get that kidney disease under control in the short term, then you add the lifestyle programs and the sugar tax on top. That's the orange one. New Zealand never brought in those SGLT2 inhibitors. They've just come in as a result of our publication on mortality. So why do you think these differences between New Zealanders of European descent, Māori and Pacific people are different? What about biological? Well, when do these differences begin? So one of the other studies we did was we looked at the babies of women in pregnancy, after pregnancy. We measured the fat and we did some cord blood sampling. And here's me measuring a little baby with some calipers. And this is the body mass index at the time. This is a long time ago, as you can see, of those European mums, P is for Polynesian, Māori and Pacific, and the women with diabetes. You can see that those with diabetes are a high BMI. Fructosamine is another measure of glucose. So even though those women who are Māori and Pacific did not have GDM, gestational diabetes at the time, they still had a slightly high glucose, which was able to feed through to the baby. No difference in fatty acids. The birth weights actually were not different in those without, in Māori Pacific versus Europeans. The subscapular fat wasn't different, it was in those with diabetes. The cord insulin wasn't, but the insulin processing, which we measure by insulin C-peptide, it's called, was different. And this is probably driven by the glucose, we think. And the leptin, even though the fat was the same, was higher in these babies. And we still don't necessarily know what they mean. So there's issues around epigenetics and intrauterine exposure to maternal hyperglycemia. And this is the latest work from colleagues in New Zealand. There's something called the CREBRF gene, which is, you can see on the top left, it's a translation factor. This is a very rare variant that there is called the RS373 and all the other numbers. It's about 5 per 100,000 in East Asians. It's 3 per 100,000 in South Asians. It's 4 per 100,000 in Europeans. And in a measure among 7,600 Africans wasn't found at all. It's 28% in Polynesians, Māori and Pacific people. But in those with this variant, what they found is that the women are 8 times less likely to develop gestational diabetes. It's a protector gene. And it increases insulin secretion, but it does something else as well. So here on the right, on the top, in the teeny writing, is what happens to body mass index if you've got this variant. They are heavier. This is more potent than the FTO gene. This is a 1.38 kilograms per meter squared increased BMI if you have this variant. But with it on the bottom, and it doesn't matter which Pacific group you are, whether you're Maori, which Polynesian group you are, whether you're Maori or Cook Island Maori or Samoan Tongan, you have about a 40% less chance of type 2 diabetes. So they've got a protector gene. So what's going on? That's one of the questions. And this is latest, this is 2020, 2018 data. So to summarize, there's a diabetes epidemic among Māori and Pacific people with increasing numbers with type 2 diabetes at an earlier age. Once Māori and Pacific people have diabetes, they have more damage, they die at a younger age. One of those people in my programs came up, he was a 47-year-old man. He said, you know, I am the oldest man on my marae, 47. You know, we are this family, we get diabetes, we get kidney failure, we die. Multiple interventions have occurred, including in partnership and tailored to the community. Still it goes on. You could say not enough, and I would definitely say, you know, why wasn't it just continuously funded? Europeans have less well-managed BP, but Māori and Pacific have less well-managed glucose. So what are the causes? Genetic, clearly are in there somewhere, but it's protective. Maybe there are others. Epigenetic, developmental origins, issues around perhaps poverty and other practices, particularly when people are younger. Intrauterine effects, pretty clear effect of high glucose going in. Social determinants as came up. These graphs are adjusted for socioeconomic status, but the higher numbers are obviously due partly to those socioeconomic issues. Access to appropriate care. Europeans also have poorer access, but the whole district has less access to care. But if you've got greater need, it's going to impact you more. These are equity issues. As soon as you aren't giving access to those SGLT2 inhibitors, that's an equity issue. And that is how we persuaded the government drug agency to fund those drugs actually it happened within a few weeks of us publishing a paper, because they've been asked to do it for 5 to 6 years. And perhaps other causes as well. Happy to answer any questions. But many thanks to all of my different teams, and also to my many mentors, my Māori, Pacific, and those of European descent, particularly in New Zealand, and of course our different funds and others. Thank you.
Thank you. That was really interesting. You really hit it at the end there. That was a great way to come around to the end of the story. Is there, we have a few minutes for some questions. So if anyone has a question they'd like to ask, I have one. Is when you got to the end and you talked about the gene that's protective, are there drugs in development that can add that layer of protection, or there might be a mechanism for a viral delivery of that to replace?
Well, you want to give people rather than replace. My understanding is that there are people working on that in Auckland. Certainly, according to the papers, that's what they're suggesting, and they're looking at that. But what's the interest? Well, there are so many interesting and in many ways sad things. Is that that's protective, and this epidemic of diabetes is in spite of 28% of the population having that protective gene.
Mm-hmm.
So it's not enough to protect them.
But even in increasing that, there's no level or any kind of titration that would make a difference, you feel, or is there any evidence either way? No.
Like you can see that's 2018 is when it came out. So this is only 2 to 3 years. But I think it's important. I think that there may be obviously other genes as well. There have been other genes identified in other Pacific groups. The HNF4 alphas, the monogenic type of diabetes genes, just as there are in one of the Native American, First Nations people in Canada has also been found to have one of those HNF, I think it's HNF4 alpha type genes. So there are some monogenic types as well. So there will be other genes involved. And that's one aspect. I think the intrauterine effect is important that we need to understand a lot more. This is an accumulator. I don't know if you know, and people listening know, that you can actually create diabetes in animals by making a mother rat get diabetes by giving it streptozocin or wiping out its pancreas, cutting it out. The baby rats get diabetes, and then the baby rats of the baby rats get diabetes. So you can generate intergenerational diabetes just by one lot getting diabetes by exposure to hyperglycemia. So there are several accumulators in this, and the genes are there, and presumably they were part of trying to protect them as they traveled across the Pacific. And there must be other genes as well, and we'll see what they are. We did do some previous work with mitochondrial genes, and they were different as well, but no one seems to have followed that up, and I left, so that's maybe something to go back to. And of course, they're involved again in energy metabolism, and that's obviously at the core of at least aspects of this.
There's a couple other questions. Let's see. Do you think that pharmaceutical companies might develop something around that gene to benefit groups outside of the one that you're studying? Well,
I'm not the one doing those studies, but I think that I think it's a university working on those at the moment. But I would be surprised if there aren't companies somewhere, pharmaceutical companies trying to work on these, because this is a pandemic. Everybody wants to give people a pill because they can make money from it and so forth. I would still say that our lifestyle programs and the policy requirements that we should be having need to move much, much, much faster and require that investment, because this is what's going to have that protection over time. The drugs are kind of short-lived, and for prevention, for example, you can see what's going on in pregnancy. Would I trust drugs in pregnancy? Well, it would depend. I do use metformin, but we don't know the long-term effects of metformin. We know it makes some babies smaller. It diverts fuel from the baby. Maybe that has some intrauterine effects. We don't know. We've got to balance the two, the glucose on the one side and the deflection on the other. We haven't learned how to use metformin properly. That's a pretty old drug. So new drugs, I think we've got to be really very careful. So I would still say, yes, we want to develop those new drugs. They'll have a cost. But lifestyle, we have to invest it. But you could see what we did, and it was still very complicated.
Here's another question from the group. Did you engage with any of the midwives or Mormon organizations within New Zealand?
Oh, that's a very interesting question. So yes, in our Tongan church, for example, the lead in one of those was a midwife. We had midwives. When you saw that picture of that baby with me measuring, those other pair of hands holding the baby was a midwife. So many of the studies involved midwife, and I've got midwives involved with things here as well. So yes, they were involved where we could within the community and also within the hospital in our diabetes and pregnancy program. And in fact, we were the first people to train up diabetes midwifery educators in South Auckland, and we published on that. And we used to have women coming in for weeks on end to manage their diabetes, and instead we had our diabetes midwifery educator go to their homes, and help them in their homes, and would work in that way. So addressing some of those access issues. So certainly midwives. And interestingly, on the Latter-day Saints side, was that we had a couple of interventions in those Latter-day Saints churches as well. And they were very supportive, and they were very big. And we thought that they were involved and there was participation, but it didn't have the same impact as the Seventh-day Adventist intervention. And we think it was because of the levels of power in that our person became the health leader. And so you've got to have an anthropological and sociological understanding of what's going on with the power structures within those communities. So we would have in one of those churches, we had someone who was a receptionist in a general practice who thought that she should be screened first before the elders, because she'd been given power through the mainstream system, which meant she was more important than the cultural structures. So that was important. That second project, Te Wa'arona Diabetes Prevention Strategy, where there was actually a Māori health manager involved, whose KPI was to have people trained, and you saw the ones that were trained, and that person did not support the continuation. She thought that the program should be run by someone Māori and not someone who was of European descent. So, you know, we very much engaged, and that was through the marae. We actually recruited 5,000 Māori through the marae. We had up to 66 glucose tolerance tests on a marae. They feed hundreds of people on maraes often, and they would come through. We'd give them breakfast afterwards, all cooked in the marae kitchens. And so yes, definitely we've done stuff through the marae, and it's, you know, it can bring quite a few people together, but you have to understand the power structures, and they're very complicated. In the urban marae, there are many tribes. And so there are internal conflicts there as well, which you need to try to work through. And sometimes internally, they aren't necessarily being managed themselves because they're trying to live together, particularly when you're poorer and you're trying to deal with this. Much stronger now. There's a lot more structure now, I think, than when we first arrived. Very complex.
So a couple more questions. When women are educated prenatally, are they educated around nutrition and diabetes, or is there not much prenatal education? How does that work?
There is. I mean, a midwife, you know, everybody will have a midwife, and a midwife's job, part of that is health promotion, which includes diet and physical activity and all of those, healthy baby and the risks of diabetes. And everyone in New Zealand now is screened early on in pregnancy. There are some issues around the screening test used, but they are all screened. So if you have undiagnosed type 2 diabetes, it would likely be found. So, you know, it is very much known and promoted. And so there are some very good structures and organized structures.
And are they educating the mothers at that time about nutrition and diabetes and everything? And is that well funded?
Does do that. The midwife does that one-to-one, but you can ask a whole range of things, which is, you know, how tailored is it? Mm-hmm. And the key thing, and I showed you the barriers to care pictures, is that it's not necessarily about the person, it's about the family around them and about the community they're in, about what's affordable, and that was some of the comments, about what's accessible. So in some of the places, it's very easy to buy the cheaper, fattier food than it is perhaps to buy the fresh vegetables and the fresh fruits. And also it's what you're used to and what do other people in the family want. So you have to really deal with this from a whole family and community perspective. And that's why we've gone for the marae-based and church-based programs to get the whole communities. So we're looking at the children of those parents, as well as the parents themselves and the wider family, the uncles, the aunts, the grandparents, and so forth.
That leads to a good final question. I think maybe there's more here. There's a lot of questions, so maybe you can type some if you have a few minutes afterwards. But let me ask this one because it goes right off of your last answer, which is, this population and problem has been studied almost since Margaret Mead. Are they not coming back and with advanced degrees and an education helping this population, working with their own people? Does that not happen?
Oh, yeah, absolutely. The initial work before I even started, there was someone, Maori there, who actually went on and has helped develop particular drugs in diabetes, came to the States. I won't comment on who it is, and done lots of things. There are Māori health professionals. They were given priority to be trained for Māori and Pacific people, you know, to be doctors. They're all the way through professors of obstetrics, I mean, everything, you know, that is, in this particular population, it is a poorer population. But certainly from the wider population, exactly, that's what's happened. And you can see the representation is there. Lots of people are trained up, and many of them are committed to their community. There's a lot of things going on, and that's part of this lesson, which is, and you know, maybe the final word is, you know, for every complex problem, there's a solution that's both simple and wrong. This is a very complicated problem, and we're not going to solve it by saying, you know, it's that person's fault, or it's all because of that, or it's all because of money, or it's all because they smoke, or it's all because, you know, they don't do enough, or it's all because, you know, we don't, you know, they don't, whatever it is. This is a whole system. It's got biology in it. It's got genetics in it. We've got to find ways to weave through all of this from a population and global health perspective.
I think that's a great place to end. And if you have time to answer any more, I'm sure that this group would appreciate it. What a fascinating discussion and a wonderful beginning to this series. Thank you, Dr. Zgibor, Dr. Simmons. Thank you, everyone, for attending, and we hope you come to the next one. Thank you.
Thank you.